All right, it looks like the number of people joining has slowed down. So we will get started. Welcome everybody to this exciting joint webinar hosted by the Dysphagia Research Society and the European Society of Swallowing Disorders. My name is Katrina Steele, and I'm the president this year of the Dysphagia Research Society, and also a proud member of the ESSD. So it's really a pleasure for us to be doing this webinar together this year, and we hope this will be the first of many future joint ventures for the two societies. I have just a couple of announcements, but first we're going to move over to a quick greeting video from Dr. Stephanie Duchatz on behalf of the ESSD.
Hello, everybody. It's a great pleasure to welcome you to this very first joint webinar of the Dysphagia Research Society and the European Society of Swallowing Disorders. It's my pleasure to welcome you from the ESSD side in my profession as head of education of the ESSD. And I am really thankful that we managed to put these webinars together. And I want to shout out a big thank you to all the people who are involved in making this possible, especially to the two amazing speakers that will share their knowledge with all of us today. It is great that we put our forces together and join our forces when it comes to dysphagia management. Therefore, I'm really thankful that our two societies organized this webinar together. And I hope you have a great evening, morning, day, wherever you are in the world right now. And maybe I will see you in person in Münster in Germany in September for the ESSD annual conference. You will find more information here. And I hope you have a great time during the webinar and hope to see you soon. Bye.
All right. Well, thank you to Steffi for that web recorded greeting to everybody. As I said, I'm the president of the DRS this year, and it's my pleasure to be joined today in moderating this session by Christina Ayeri for the ESSD. Before we get to our two speakers, I have just a couple of announcements from DRS to share. And I'll just go back here. The first is to highlight that we're still in June. And in fact, the motivation for this, are you seeing presenter view? I'm sorry, you might be. The motivation for this joint initiative was that June is Dysphagia Awareness Month, and we thought that was a perfect opportunity for a joint webinar. On the DRS side, June is also our fundraising month, and we've been running what we call our Dash for Dysphagia. And I don't have the latest total of funds raised, but at last information to me, we were really close to $10,000, and we would really love to get over that target. And so if you're a DRS member and haven't yet donated, please think about going to the link here on the slide and supporting this effort, which raises funds to bring scholars to the society, people like Dr. Emma Wallace, who's our speaker here, who was a new investigator recipient. And so this is a really worthwhile cause to help people come to the meeting. And on that note, our next meeting will be held next year in Philadelphia from March 25th to 28th. Please mark this in your calendars. It's going to be a really great meeting, not to be missed. And we really hope that all of you will join us. And with that, I will stop sharing and pass over to Christina.
Great. Thank you very much, Katrina. And as Katrina mentioned, my name is Christina Ere, and I'm here today co-moderating with Katrina on behalf of the European Society for Swallowing Disorders. And I think we probably can get started with our presenters this morning. So on behalf of the ESSD, it's my great pleasure, and the DRS as well too, my great pleasure to be introducing our first speaker this morning, or first speaker today, and that is Dr. Hanne Massonet. So thank you very much for being here with us today. She comes from the research group Experimental Otorhinolaryngology and Decantology from the KU in Louvain in Belgium, from the Department of Sciences. She also has affiliations with the University of Antwerp, Department of Translation Sciences, and the Department of Surgery and Swallowing Clinic at the University Hospital. So she's will be presenting to us her work titled Adherence to a Home-Based Intensive Treatment Program, including non-invasive brain stimulation for chronic radiation-associated dysphagia in head and neck cancer survivors. So the feasibility of the HIT-CRAD trial. So so thank you very much for being here, and we will now turn over to Hanne.
Hi everyone, and thank you all for being here. Whether you're enjoying a morning coffee, a lunch break, or an evening wine or tea, I'm happy to have you join us today. So a very warm welcome to all of you. Let me just shortly introduce myself. My name is Hanne Massonet. I'm a speech and language pathologist at the University Hospitals of Leuven, and I'm currently doing a joint PhD at the Universities of Leuven and Antwerp under supervision of Professor Goeleven and Professor Van Nuffelen. I'm very honored to have the opportunity to share my award-winning poster presentation with you. And before we dive into the details of our research, I'd like to start by showing you the poster itself. As you can see, our research is focused on dysphagia rehabilitation in head and neck cancer patients. And today I would like to present to you our data on adherence to a home-based treatment program, including non-invasive brain stimulation for chronic radiation-associated dysphagia in head and neck cancer survivors. It's the feasibility of our ongoing HIT-CRAD trial. Let me begin by clarifying this term radiation-associated dysphagia. Around 80% of head and neck cancer patients undergo radiotherapy at least once during the course of their disease as a primary or adjuvant treatment. And despite its effectiveness, radiotherapy may induce collateral damage to uninvolved normal tissues, which may lead to severe and chronic radiation-associated dysphagia. The major reasons for chronic radiation-associated dysphagia seem to be fibrosis, muscle atrophy, lymphedema, and cranial neuropathies. And eventually, this will result in reduced range of motion and strength of the swallowing musculature. And this impairment will affect both the oral and pharyngeal phase of swallowing. So patients are at risk for penetration or aspiration of food and liquids. And as a result, patients often tend to eat or drink less, which will then enhance further loss of muscle fibers, causing a negative spiral. And when this is not effectively treated, dysphagia can cause malnutrition, dehydration, aspiration pneumonias, and reductions in quality of life and social and psychosocial well-being. The major impact of these toxicities on the patient's health and quality of life and healthcare resources has led to growing interest in effective exercise programs to prevent and reduce dysphagia symptoms in this population. And therefore, we designed a 3-arms, multi-center randomized control trial to compare the efficacy of 3 reactive therapy programs in 54 patients whom we randomly divide in 3 groups. And this study represents a nice collaboration between researchers from 3 university hospitals in Flanders, namely the University Hospitals of Leuven, Antwerp, and Ghent. The HIT-CRAD study is carried out in patients with a history of head and neck cancer treated with primary radiotherapy or chemoradiotherapy at least 6 months ago. Eligible tumor sites are the oral cavity, nasopharynx, oropharynx, hypopharynx, and larynx. And we include patients with a diagnosis of chronic radiation-associated dysphagia, which is present for at least 3 months. The duration, frequency, and location of the therapy programs are the same in each group. So all patients practice 4 days a week for 8 weeks, and the therapy takes place at home under supervision of a qualified SLP. The exercise program, however, differs according to the group. Since one of the reasons for chronic radiation-associated dysphagia seems to be reduced range of motion and strength of the oropharyngeal muscles, strength training may serve as an ideal rehabilitation tool. Therefore, the first group receives 8 weeks of exercises aiming to improve strength of the swallowing musculature. So far, numerous studies have shown the benefit of these strengthening exercises in head and neck cancer patients. And in some studies, an increase in strength did seem to result in an increased swallowing safety or efficiency, but a significant change in functional oral intake was not yet observed. Which means that although we can improve a patient's tongue strength, that doesn't necessarily mean that this patient will be able to eat more challenging consistencies. And with that being said, strength training can certainly be a treatment in itself if muscle weakness is the underlying cause of dysphagia. But perhaps strength training can produce greater functional gains when used as a pre-training for functional swallowing training. And during an ESSD webinar in April, Professor Huckabee encouraged us to think out of the muscle and into the brain, and to broaden our focus beyond muscle strengthening and consider the role of the brain in dysphagia rehabilitation. And indeed, in some head and neck cancer patients with chronic radiation-associated dysphagia, a decreased coordination between the various phases of the swallowing process is observed, which might be associated to the dose applied to the inferior section of the brainstem, where the central pattern generator is located. Therefore, we added a second group in which we combined 4 weeks of strengthening exercises with 4 weeks of bolus-driven functional swallowing training or skill training, since we assume that this may lead to greater functional gains. During the swallowing training, we follow the guidelines of a standardized bolus-driven therapy program called the McNeil Dysphagia Therapy Program, in which a food hierarchy is used to gradually increase volume, consistency, intensity, and timing of swallowing. So patients start at a certain level and move forward with a series of successful swallows or backwards with a series of unsuccessful swallows. A small case series, a recent pilot study by Charters and Clark, and some preliminary results on the evolution of the bootcamp swallowing by Professor Hutchison and colleagues report promising results of this bolus-driven swallowing training in head and neck cancer patients. In the third group, neuromodulation is added to the strength functional therapy combination of the second group, and I'd like to explain on that a bit. In recent years, the role of cortical control of swallowing has become more apparent. Novel stimulation methods that concentrate on modulating cortical activity to improve deglutition, such as transcranial direct current stimulation or transcranial magnetic stimulation, were investigated. TDCS, for example, is explored in both healthy and clinical populations as a type of augmentation. So that idea being that, on the one hand, it can be used to enhance the recovery of impaired motor function by promoting spontaneous neuroplasticity, and on the other hand, to facilitate motor learning during training. And there is evidence that repeated application of TDCS induces changes in connectivity in the neural network by modulating the membrane potential in the direction of depolarization for anodal stimulation. And it has been shown that better behavioral effects are achieved when TDCS is combined with behavioral training, suggesting that it may act as a learning enhancer in healthy individuals as well as in neurological patients. So with this in mind, we thought it would be interesting to investigate whether high-definition TDCS might be of added value in the rehabilitation of chronic radiation-associated dysphagia. In our study, the high-definition TDCS is applied 4 days a week during behavioral therapy. All sessions are completed within 8 weeks, giving a total of 32 TDCS sessions. And the stimulation is administered bilaterally, so each hemisphere is stimulated alternately for 2 consecutive days with a constant direct current of 2 milliamps applied for 20 minutes with a fade-in, fade-out of 30 seconds. And our goal is to stimulate the oral and pharyngeal motor cortex, which are located in the precentral gyrus. So we searched for studies describing the fMRI coordinates for these areas and then entered these into a software provided by Sotrix Medical. And with the simulation software, we were able to determine for different electrode configurations how we can stimulate these areas as precise as possible. And if we look at this figure from a paper by Professor Humbert and colleagues showing activation in the pre- and post-central gyrate during swallowing, these cortical areas seem nicely located within the stimulation field we provide. And by using a cap, we apply 5 electrodes according to the 1020 EEG system. Here you can see a photo of the patient wearing the cap with the electrodes. Let me now provide you an overview of our study protocol. As you can see, with the second group receiving sham high-definition TDCS, we will be able to evaluate the possible additional effects of high-definition TDCS on muscle strength and swallowing function. And in the sham group, the same protocol is applied. However, the 2 milliamp current is ramped up for only 30 seconds and then switched off, which produces an initial tingling sensation but no significant changes in cortical excitability. Now, the ultimate goal of the HIT-CRAD study is to find an effective and evidence-based swallowing therapy program to optimize the functional abilities of patients with chronic radiation-associated dysphagia. In addition to the efficacy of a therapy program, it's also important to consider its feasibility. In other words, how well do patients adhere to the therapy program, and are there any significant side effects? Therefore, we examined the feasibility of our ongoing HIT-CRAD study in a subset of 36 patients. Mean age of the included patients was 49 years, and 70% were male. The majority of patients received chemoradiotherapy as primary treatment, and the time between completion of radiotherapy and the start of our therapy program was about evenly distributed. The first goal of this feasibility study is to evaluate the feasibility of this treatment program by means of weekly adherence rates for all groups. The second goal is to explore the feasibility and safety of this long-term, home-based application of real and sham high-definition TDCS in head and neck cancer survivors. In terms of adherence, the success of any therapy program is dependent on the level of adherence. Several clinical studies and reviews indicate that achieving high adherence is challenging within the head and neck cancer population. And the reasons for this are multifactorial. Both disease and patient-related factors play a role, but also characteristics of the therapy program itself and the healthcare professionals providing therapy impact adherence. For example, does the patient practice independently or under supervision of an SLP? And how is the relation with this SLP? We also know from previous studies that the use of biofeedback has a positive impact on adherence. And finally, patient adherence seems to be affected by the exercise dose, which is based on 4 key components. First of all, intensity, which reflects the amount of effort or load that is placed on the muscle. The second dose parameter includes the number of repetitions you want your patient to perform in one set of a specific exercise. And then frequency defines how many sets of exercise are performed in one day or session and how many days of exercise per week. And then lastly, duration is the total length of the exercise program. And with these components in mind, we designed the following strength training program. By combining these different strengthening exercises, we hope to target all the important muscles involved in the oral and pharyngeal phase of swallowing. So tongue strengthening exercises are alternated daily with chin tuck against resistance and EMST to enable muscle rest and recovery. And patients in our study train at 75 to 80% of their 1 repetition maximum with a high number of repetitions over an 8-week period 4 times per week. So in our study, we selected a training regimen that combined high resistance with a high number of repetitions. Nevertheless, this appears certainly feasible for head and neck cancer patients because our results demonstrate that patients who begin the exercises are able to complete the session in 98 to 99% of the cases. We also examined the overall adherence over 8 weeks. And overall adherence was expressed as the percentage of completed sessions per week. And this remained high in all groups despite the high loads and high number of repetitions during strength and skill training. The feasibility of our protocol was further confirmed by the very low dropout rate in our study, with only 2 unintentional dropouts due to tumor recurrence and severe malnourishment. Now, one of the reasons for the high rate of adherence in our study may be attributed to our focus on the implementation of behavior of change techniques derived from behavioral sciences. Recent research on the use of these techniques within interventional studies in head and neck cancer patients has revealed that the following techniques are the most commonly described in interventional studies. Furthermore, the following 4 techniques were most prevalent in studies with positive outcomes. And these 7 techniques were also incorporated in our study protocol, which may have contributed to our high adherence rates. However, it is likely that the most significant factor for high adherence in our study is that the treatment was conducted at home under daily supervision of an SLP. And this is beneficial for the patient and in some cases for us therapists as well. Now, this is not something new because previous research has already demonstrated the value of face-to-face therapy. The PRESTO study, recently published in Dysphagia, examined the impact of adherence-enhancing strategies on the actual adherence of head and neck cancer patients performing preventive swallowing exercises during chemoradiotherapy. So patients either practiced at home with an app or paper logbook or daily with the therapist after radiotherapy. The results showed that adherence rates were the highest in the therapist group, suggesting that face-to-face contact might be an important facilitator for adherence. Which is, of course, lovely to hear for us as SLPs. However, daily face-to-face therapy has its limitations in terms of feasibility and cost-effectiveness, so we might need to search for ways to increase self-management. Because effective self-management enables patients to take an active role in managing their recovery process. An interesting randomized control trial was recently published showing positive effects of weekly counseling sessions during chemoradiotherapy, apart from 3 SLP visits, to encourage adherence to the preventive swallowing exercises. And this study showed that patients who received both the counseling sessions and SLP visits were more likely to adhere to the preventive swallowing exercises compared to the control group who only received the 3 SLP visits. So this study provides a nice illustration of the potential benefits of encouraging self-management to enhance adherence. I would now like to move on to our second goal, which was to explore the feasibility and safety of this long-term home-based application of real and sham high-definition TDCS in head and neck cancer patients. To evaluate the safety of the high-definition TDCS, a standardized questionnaire was used to assess the side effects of the high-definition TDCS after each session. Our results show that administering high-definition TDCS at home is safe and feasible because no serious side effects related to high-definition TDCS were reported. The most reported side effects were mild to moderate tingling, itching, or burning sensations, but stimulation was well tolerated and never needed to be stopped or interrupted due to severe discomfort. So the severity and nature of our side effects are consistent with those reported in previous studies. So this leads us to the conclusion that our HIT-CRAD protocol is safe and feasible, because this feasibility study demonstrated high adherence rates in head and neck cancer survivors with chronic radiation-associated dysphagia who completed a high-volume strength and skill-based exercise program with neuromodulation under continuous supervision. Furthermore, our results confirm that home-based application of real and sham high-definition TDCS during therapy is safe, feasible, and well-tolerated in this population when safety standards are taken into account. I hope I was able to give you a thorough overview of our study protocol. But for those of you who would like to learn more about our HIT-CRAD study, you can always find more information in our paper that was published in Trials. As I already mentioned, the ultimate goal of the HIT-CRAD trial is, of course, to compare the efficacy of these different training programs in terms of swallowing function, muscle strength, and quality of life. And we are now about to finalize our data collection. So far, we've included 52 out of the planned 54 participants, and the last 2 participants will be initiated in early July. Therefore, we hope to start the statistical analysis of our data very soon to compare the efficacy of the different training programs. So let's hope we will be able to present the efficacy findings on the DRS conference next year. In closing, I would like to thank the board of the DRS and ESSD for the opportunity to present today and all of you for joining us. I'm more than happy, of course, to answer any questions you may have during the Q&A session, but please feel free to email me if you have any further questions.
Wonderful. Thank you, Hanne, for that recorded presentation. I was neglectful at the beginning to explain that we invited Hanne and Emma to present today because they both won awards at the recent conferences. So Hanne's presentation won a Best Poster Award at the ESSD Congress last year. And Emma is the first place New Investigator Award winner for the recent DRS conference this year. We're going to hold questions and answers until after both recorded presentations. So it's my pleasure now to introduce our second presentation, which will be delivered by Dr. Emma Wallace, who is a senior lecturer at the University of Sydney in Australia. Thank you for joining us late at night. Emma leads the dysphagia research and teaching programs there. Emma's talk is entitled Nocturnal Swallowing and Obstructive Sleep Apnea and the Effects of Continuous Positive Airway Pressure. We can roll that video. Thank you.
Good evening, good afternoon, and good morning, everyone, depending on where you're tuning in from. I'm delighted to be here and to present this research on nocturnal swallowing in obstructive sleep apnea and the effects of continuous positive airway pressure that was awarded the 2024 DRS New Investigator Award. For those of you who don't know me, my name is Emma Wallace. I am a senior lecturer in the discipline of speech pathology at the University of Sydney in Australia. And I lead the dysphagia research and teaching programs here at the University of Sydney. And my research program focuses on the relationship between breathing and swallowing and airway protection, assessment and treatment, and implementing research evidence into clinical practice. On a side note, I am just recovering from COVID. We're in the depths of the Australian winter here at the moment, so I apologise for the slightly hoarse and nasal sounding voice. Here are my disclosures. So to start with a little bit of background, this study arose from my postdoctoral work in the Department of Sleep Medicine at Flinders University in South Australia. I spent many of nights in this little room observing sleep studies in patients with sleep disordered breathing. These patients were heavily instrumented to better understand the pathophysiology of their sleep disordered breathing, with a pneumotachograph to measure breathing, a full set of sleep EEG electrodes, a pharyngeal pressure catheter, and intramuscular EMG into the genioglossus muscle. And believe it or not, they did in fact sleep despite all the instrumentation. And during the night, I noticed, interestingly, that these patients were swallowing quite frequently throughout the night. And their swallowing often deviated from the typical expiration swallow expiration pattern that we might expect. In addition to this, their swallowing seemed to coincide with this cortical arousal from sleep, where the brain momentarily transitions from a sleep to awake state that is observed on the EEG signal, but the individual remains visibly asleep. So these observations really intrigued me, and at the time, swallowing was considered this annoying artifact by my sleep medicine colleague, and they used to try to get rid of swallowing. But these observations interested me and prompted me to start a research program looking into nocturnal swallowing and sleep-disordered breathing. So, for those who don't know, obstructive sleep apnea is a highly prevalent sleep-related breathing disorder that affects approximately 1 billion people worldwide. OSA is characterized by this repeated narrowing and collapse of the upper airway during sleep, while the airway remains perfectly patent during wakefulness. And OSA is associated with a vast array of health, societal, and economic consequences, including cardiovascular disease, metabolic disease, daytime sleepiness, workplace errors, and road traffic accidents. So the consequences of OSA are extremely high. We know that the process of swallowing shares the same anatomical and neural structures that are implicated in obstructive sleep apnea. And previous studies have shown that individuals with OSA do experience dysphagia. The nature of dysphagia in OSA is likely related to sensory motor changes in the upper airway that arise from repeated episodes of airway narrowing and collapse throughout the night, resulting in a large degree of upper airway trauma. However, dysphagia in OSA appears to be largely subclinical in these individuals, in that it doesn't seem to largely impact swallowing safety or functional eating and drinking in these individuals during wakefulness. However, the relationship between swallowing and obstructive sleep apnea gets a little bit more, I suppose, complex or interesting when we look at nocturnal or nighttime swallowing. We know that nocturnal swallowing occurs approximately 2 to 3 times per hour in healthy individuals, and it likely serves as an important airway protective and clearance mechanism, clearing secretions or saliva from the pharynx, as well as reducing tracheal aspiration during sleep. Interestingly, recent research has shown that nocturnal swallowing is associated with these marked increases in heart rate and blood pressure and cortical arousal from sleep, where the brain momentarily transitions from this sleep to wake state, despite the person remaining visibly asleep. And the reason why this happens remains somewhat elusive. However, we do know that individuals with obstructive sleep apnea swallow approximately 10 times more during sleep than healthy individuals. And this is also true for individuals with Parkinson's disease and cervical spinal cord injury, in which OSA is highly prevalent, up to 82%. But this means that these individuals are experiencing these regular spikes in heart rate and blood pressure and cortical arousal from sleep throughout the night, which are hallmarks of obstructive sleep apnea. So these data and our prior observations raised the question of whether nocturnal swallowing was related to obstructive sleep apnea severity due to these vast increases in heart rate and blood pressure and cortical arousals from sleep. I also wondered whether nocturnal swallowing impairment, which I characterized as deviations from typical breathing swallowing patterns during sleep, was also associated with OSA severity. And lastly, I wondered whether nocturnal swallowing changed across different sleep states or sleep stages due to the prior observations that nocturnal swallowing seemed to coincide with this cortical arousal or brain awakening from sleep. In terms of obstructive sleep apnea severity, this is characterized by the number of times the airway narrows or collapses per hour of sleep, which is measured using the AHI or apnea-hypopnea index. So mild OSA is characterized by an AHI of 5 to 15 events of airway narrowing or collapse per hour of sleep, moderate OSA 15 to 30, and severe over 30 events per hour of sleep. And CPAP, or continuous positive airway pressure, reduces airway narrowing and collapse by splinting the airway open, and therefore reduces obstructive sleep apnea severity. So with regards to our study aims and hypothesis, we aimed to evaluate the relationship between nocturnal swallowing frequency and obstructive sleep apnea severity, and we hypothesized that these would be positively correlated. Secondly, we aimed to evaluate nocturnal swallowing frequency across different sleep stages or sleep states, and both on and off CPAP. And we hypothesized that nocturnal swallowing frequency would change across different sleep stages and would be lower on CPAP. And lastly, we aimed to evaluate nocturnal breathing swallowing patterns, both on and off CPAP. And we hypothesized that individuals with OSA would have deviations from typical expiration, swallow, expiration, breathing, swallowing patterns. So we conducted a secondary data analysis with 32 individuals, 25 males, 7 females, which is relatively representative of the OSA population. These individuals were middle-aged with a high BMI and severe OSA, and we evaluated 3,399 nocturnal swallowing events. Participants were instrumented with a pneumatic tachograph on the picture on the left-hand side to monitor their breathing, a full set of sleep EEG electrodes on the scalp, and they also had a pharyngeal pressure catheter as well as intramuscular EMG into the genioglossus muscle. And they spent 50% of the night on therapeutic CPAP. In terms of the sleep studies, these were independently scored by a sleep technician using the American Academy of Sleep Medicine criteria. And this evaluates the following stages of sleep. So stage 1, stage 2, and stage 3. So getting into increasingly deep sleep, REM or rapid eye movement sleep, and arousal or wakefulness. In terms of nocturnal swallowing, this was identified using a swallowing analysis application that was written in MATLAB by my biomedical engineering colleague. And it identified as sharp rises in pharyngeal pressures that coincided with instances of zero flow. And the breathing swallowing pattern was subsequently extracted automatically from the flow signal. So moving on to the results, we saw a positive correlation between swallowing frequency or nocturnal swallowing frequency and apnea-hypopnea index or OSA severity. And this was consistent both on and off CPAP. Looking at nocturnal swallowing across different sleep stages, we can see that the majority of nocturnal swallowing events were associated or occurred alongside a cortical arousal from sleep or during wakefulness from sleep, with a small proportion occurring during the lighter sleep stages, so stage 1 and 2, with very little instances of nocturnal swallowing occurring during deep sleep, so stage 3, and REM sleep. Looking at nocturnal swallowing frequency, both on and off CPAP, we can see here that the majority of nocturnal swallowing events occurred off CPAP compared to on CPAP, despite 50% of the night spent in each state. And this was consistent across all sleep stages, where nocturnal swallowing frequency was higher when individuals were off CPAP compared to on CPAP. Looking at nocturnal breathing swallowing coordination, we saw that overall 64% of swallowing events deviated from a typical expiration swallow expiration pattern. And again, this was consistent both on and off CPAP, where 58 to 67% deviated from the typical expiration swallow expiration pattern. So in conclusion, we saw that nocturnal swallowing frequency was related to obstructive sleep apnea severity or the frequency of airway narrowing and collapse throughout the night. And the mechanism of this is still unclear. However, it's likely related to this sharp increase in heart rate and blood pressure and cortical arousal from sleep that we know occurs during nocturnal swallowing, that further increases the risk of airway narrowing and collapse in these individuals. Secondly, we saw that nocturnal swallowing frequency changed across sleep stages, with less nocturnal swallowing in this deeper sleep, in the deep sleep stages, so stage 3, and the highest nocturnal swallowing frequency occurring during cortical arousal or wakefulness. And I think this observation shed some interesting light on the neural control of swallowing and perhaps the importance of the cerebral cortex in swallowing from this slightly different perspective. And lastly, we saw that nocturnal swallowing in OSA deviates from the typical expiration, swallow, expiration, breathing, swallowing pattern that we might expect. And this was similar both on and off CPAP, so likely not related to OSA severity. However, we hypothesized that this may be related to sensory motor changes in the upper airway that arise from upper airway trauma from repeated episodes of airway narrowing and collapse throughout the night. And this may also explain some instances of dysphagia in OSA during wakefulness. So thank you very much for your attention. I am very happy to take questions, comments, criticisms, and my email is also there if you'd like to contact me. Thank you very much.
Wonderful. Thank you both for those presentations. We have time for questions and answers, and we'd like, if the audience could please type those into the Q&A box at the bottom of your Zoom screens. And we'll try to take turns to the degree that questions come in. We'll need a couple of minutes, I think, for questions to come in. But Christina, I had put a question in our chat about Hanne's presentation. Maybe you'd like to moderate for those.
Yeah, absolutely, Katrina. That's not a problem. The first question is Hanne. Could you explain the sham condition for your TCDS component? I noticed that they also describe burning sensation, so Katrina was curious about that.
Mm-hmm. That's a good question, thank you. In the sham condition, the 2 milliamp current is ramped up for 30 seconds and then immediately switched off. So this produces these initial tingling, burning, itching sensations, but no significant changes in cortical excitability. So that is why these patients do feel some side effects without noticing that they're receiving sham stimulation. Yeah.
And is there evidence that that's a true sham compared to your other condition from previous TCDS experiments?
Yes, it is. It's investigated thoroughly that this sham condition for TDCS is a good sham condition. But of course, when the data collection is completed, we would like to see whether there are really significant differences between sham and the real TDCS. We also question patients whether they think they receive real or sham stimulation. So we're very curious whether patients can really differentiate between those two conditions in our study. Yeah.
That'll be really interesting. All right, so moving over to a question for Emma then. Emma, Karen Malherbe has asked what your suggestion would be for the clinical application of the association you've identified between OSA and nocturnal swallowing patterns.
Yeah, thanks for your question, Karen. Hopefully you guys can hear me okay. Really interesting. I think this study was so exploratory and kind of arose from some interesting observations that I saw in the lab. I think one thing that we've been discussing, and actually that was discussed at DRS, was really whether this nocturnal swallowing frequency or seeing this really high rate of nocturnal swallowing frequency could be a marker of OSA potentially. So whether it's contributing to OSA, and I don't think we fully understand that yet. But yeah, whether this high frequency of nocturnal swallowing could be a marker or a clinical indicator of OSA. And I think this kind of research will also, we haven't looked into this in detail yet, but it also kind of relates to some instances that we see in premature infants who are experiencing high frequency of nocturnal swallowing, and also relating to SIDS, or sudden infant death syndrome, and the long apneas that premature infants also have. So there's a few clinical applications that we're exploring, but as I said, this research kind of stemmed from really an interesting observation that I had sitting for hours on end in the lab at night. So interested to hear some thoughts as well that others have in the audience.
Thank you. Christina, back to you.
All right, thank you. We'll move on to the next question. This is a question for Hanne from Stacy. If you could repeat the reasoning behind the TCDS having an impact on impairment, cost to tissue, and associated physiological functioning.
Yeah, thank you, Stacey, for that question. I do agree that it might be controversial to think that this, what seems to be a mainly peripheral pathology, could benefit from this centrally driven technique. However, there is emerging evidence that radiotherapy does not only have an impact on the peripheral nervous system, but also on the central nervous system. And therefore, I think it's interesting to investigate this black box and see whether the use of high-definition TDCS might facilitate our neuroplasticity when applying these techniques to improve motor learning. Because there is evidence that TDCS induces changes in the connectivity in the neural network. So therefore, we just wanted to see whether it might be of added value and to improve the efficacy of our treatment programs in this patient population that seem to be quite resistant to these existing therapeutic approaches.
Great, thank you for that, Hanne. Back to you, Katrina, I think.
Thank you. This question came in from Marta Kazanjan for Emma. Marta says she typically does something called a stop bang screen. And I don't know what that is, so I hope you can explain that. But they do this for their outpatients before they see them for video fluoroscopy. And she asks what else can be done in the clinic to be mindful of how OSA might be impacting the dysphagia that they see in patients across populations.
Great, thanks for your question, Marta. It's interesting that you guys are doing this. So the stop bang, for others in the audience, is a screening tool for OSA, so a screening questionnaire. So it's interesting that you guys are doing that. I don't know if many clinical teams do that. And I think it's interesting, dysphagia in this population, because we don't seem to see, or what the research evidence seems to suggest is, we don't seem to see a huge impact on functional eating and drinking or swallowing safety or efficiency impairments in these individuals. I know when they're when their swallowing is evaluated under instrumental assessment in individuals with obstructive sleep apnea with no other comorbidities like stroke or progressive neurological disorders, we don't seem to see a large impact alone of OSA on functional eating and drinking or swallowing safety and efficiency. But I think when we often know that OSA co-occurs, in individuals who've had stroke, progressive neurological disorder. And I think that in combination with some of those other comorbidities, it can potentially exacerbate swallowing impairments that we see in these individuals. So I don't think we fully understand the relationship or the contribution of OSA yet. I think we're kind of still learning this, but I think it's interesting to know that these, potentially if you have a stroke survivor or a patient with a progressive neurological injury, it's interesting to know whether they have OSA or a history of OSA, because it will influence their upper airway, how it functions, sensory motor changes that we know occur from this. If we saw up to 30 times per hour, the airway can be narrowing and collapsing during sleep in these individuals with severe OSA. So the level of upper airway trauma in those individuals is really high. And we know it does impact upper airway sensation and potentially motor control as well. So knowing it could influence, the severity of dysphagia that you might be seeing in those individuals.
Great, thank you very much for that. answer. We have another question for Hanne, coming in from Barbara Sonies. A question about the cost of the apparatus and how does it get fitted to each client for home use?
The cost of the TDCS is really varying between the different devices that you use. For the high definition TDCS, if I remember correctly, it's about 15,000 euros, but there are much less expensive devices on the market as well. And with regards to the fitting, as I mentioned, we use this cap where we apply the electrodes on the cap. And each time when we apply the cap, we measure from nasien to inion and then from tragus to tragus to see that our 1020 EEG system cap is really placed correctly on the patient's head. We also have different sizes of the cap for each head size. So that's how we fit this at the home setting.
Super. I have a question for Emma. This is actually from me, Emma. I'm curious, I would notice that you were describing really careful methods to have a pharyngeal pressure catheter, and then you had genioglossus EMG and to pick up swallows in your data collection methods. And then you describe these events that happen multiple times per hour of pharyngeal collapse. And I'm just curious, is there a different pharyngeal pressure signal that's associated with collapse that isn't part of a swallow?
Yeah. So yeah, really good question. Yeah, so in the obstructive sleep apnea or in the sleep medicine world, they use these kind of just single pressure sensor catheters. That's it. They call them epiglottic or epiglottic pressure catheters. But they sit just kind of well above the epiglottis. But yes, in terms of like an obstructive event, it would be much longer than what we would see with a swallow. So typically they're much longer. And I mean, it looks similar, but you obviously have zero airflow with these obstructive events as well. So we're seeing, pressure in the pharynx as well as zero airflow for much kind of 10 seconds or longer sometimes. It's actually sometimes scary to watch these individuals sleep with how long these apneic events can last. I think I had a few instances of almost wanting to run into the room, like just being afraid, just watching them sleep. But yeah, it's really timing. I think obviously with swallowing, we're seeing this, very quick, rapid closure and reopening of the airway. So swallowing is quite easy to identify with the instrumentation that we have. But I think largely my sleep medicine colleagues used to, swallowing is like an annoying artifact for them that they would just try to exclude from all their signals for analysis, which was quite interesting until we started exploring this in a little bit more detail. But yeah, they look completely different on the waveforms.
Thank you. Over to you, Christina.
Yeah, thank you. And I'm actually going to turn this. This is also another question from Katrina, but also for Hanne. With regards to, you have 3 components and control arms within your study, meaning you must need a large sample size. So the question from Katrina is, how are you finding recruitment for this large study?
I'm sorry, I didn't really capture the question. Could you repeat it?
You must need a really large sample size given your eloquent design with essentially 6 conditions. And I'm just wondering how recruitment is going for such a large sample size. And do you have any insights about that?
Well, in the beginning, our aim was to include 105 participants. And for the primary outcome measure, we wanted to be able to compare a change in functional oral intake between any 3 groups. However, after 3 years of data collection and many efforts to increase our inclusion rate, we noticed that we weren't able to achieve this sample size. And so then we had a meeting with our statistician again to see if there was any way to reduce our sample size. So we had to reduce it, but in a valid way.
The sample size is now reduced to 54 participants. And this is done because we will now, for the primary outcome measure, which is a change in functional oral intake, we will make a comparison between patients who received only isolated strength training, so the first group, and then patients who received strength functional swallowing training in the second and third group. So the second and third group will be combined and compared to the first group for the primary analysis, which changed our significance level, and therefore we were able to reduce our sample size. But of course, for the secondary analysis and the additional effect of high definition TDCS, we can still make comparisons between any three groups. But it was a very large. We were very hopeful when starting the study, but unfortunately, it was really difficult to find all these patients and deliver these home-based treatments all over the country. So yeah, we needed to adjust it, but we're very confident that we still have some nice results, because up till now we do have 52 of the 54 planned 54 participants. So.
That's great. 54 is still in swallowing trial research. That's a big number. So especially because you have multiple visits, right, for these people. So congratulations. I'll ask one last question for Emma, and then I think we will wrap it up. So Emma, a couple of questions from Tessa Goldsmith, so we'll ask them together. One is to understand how esophageal reflux disease is taken into consideration in your research, and how might that be contributing to this arousal and swallowing pattern that you see during sleep. And then secondly, to understand whether your sleep medicine colleagues have become more interested in nocturnal swallowing as an outcome of your research, and how you see this leading to collaborations.
Yeah, thanks, Tessa, for your questions. In relation to the first one about the reflux or GERD, it's such a valid point, and I think we know a lot of patients with obstructive sleep apnea do have reflux. We didn't in this study. It wasn't because it was a secondary data analysis. We didn't specifically factor it in this study, and didn't collect data on it in this study. But it is something that we will take into account, and I think it's. Yeah, I think it's a question that has come up for me a lot. Like, why is this? Why are these individuals swallowing so frequently throughout the night? Is it reflux? Is it something else? I would imagine reflux is a contributing factor, but I think there's other things going on as well. But that's a great question. And in relation to your second question, yes, I think the field of swallowing and sleep medicine is definitely becoming a little bit more aligned or more familiar. They're definitely interested in nocturnal swallowing and how it maybe contributes to the severity of obstructive sleep apnea, and better understanding that relationship. I think it's so interesting that these, we're researching really the same areas of the body. They're looking at it during the night, and we're obviously mostly focusing during wakefulness, but it's so interesting how the upper airway changes completely when these individuals fall asleep, which I think is really fascinating. And I think there's a lot we can learn from their methods of assessment, and also I think there's a lot that they can learn from our discipline in terms of our understanding of upper airway physiology as well. So yeah, lots of collaboration, and I still work very closely with the team at Flinders as well. So yeah,
Wonderful.
Lots of collaborations.
Well, thank you both for your outstanding presentations. I want to share that comment from Dr. Barbara Sunnies, who said she wanted you both to know that your presentations were excellent and relevant with very well thought out methodologies. And I'll echo her kudos to both of you for those outstanding presentations. Thank you to Christina also for helping to moderate. And thank you to all of you in the audience for asking your questions. This will be recorded and made available through the Society websites for later viewing. And I just want to then go back and just remind people of two important events. And I think so first of all, to remind all of you of the upcoming ESSD Congress, which will be in Münster at the end of September. Registration is already open for this Congress, and we will hope to see many of you in person at that event. And then again, to remind you to hold the dates for next year's DRS meeting in Philadelphia, where we also hope to see you in person. And the call for abstracts will be opening in July, we hope, with a deadline at the end of September. So if you're a researcher, please start thinking about what you would like to submit to that meeting. And with that, thank you all for participating. We wish you a good day, a good night, wherever you are in the world. And thank you again to our presenters.